Okay, so for this last final module, we're going to talk about ulnar-sided wrist pain and TFCC injuries. It's going to be pretty foundational as this is a pretty complex area to be injured and a really complex area to treat. But we're going to get into it just briefly, just so that you're not necessarily blindsided if perhaps you were to see it in the clinic. If you find it a fun rabbit hole like I did, you can kind of study more into it, seek more resources to kind of get a better familiarity with this, and then maybe one day you'll be able to treat this as well. But it's very fun, very interesting. So going on, we have just kind of the quick overview. I'm going to introduce what it is, discuss what the anatomy is, relevant anatomy considering TFCC and the ulnar side of the wrist. How do patients come into the clinic and present, provocative testing for TFCC, and then lastly, evaluation and treatment. I will say that the eval section is going to be pretty bare. Um, as this is the very last module, I challenge you to kind of use your own knowledge and clinical mindset to apply your information from what they're presenting, what their limitations are, the anatomy, and kind of get an idea of what perhaps you might do. Obviously, some of this provocative testing will be absolutely amazing to include in your evaluation. But when it comes to the types of questions that you might be asking and how you might start an initial treatment session in your HEP, think about that a little bit yourself and challenge yourself and consult with your clinical instructor and or any professor who has familiarity with the upper extremity in your school and kind of like test your ability to kind of like think critically here. So getting into the overview, let's see here. So, first of all, when we talk about ulnar-sided wrist pain, I'm referring to pain that is located on the pinky finger side or the little finger side of the wrist. So, it's a small but very complex region that involves structures like the TFCC. So, that's the abbreviation for it, but it stands for triangular fibrocartilage complex. Um, and also consists of the ulnar head and then also the ECU tendon, so the extensor carpi ulnaris. It can be a tricky area to treat and diagnose because of all of these small and clustered structures. But really, when we think about, there are two major types of causes that we need to think about. So we have traumatic and degenerative. So traumatic causes might include things like a fall on an outstretched hand, so a foosh, which can be common for like athletes or even older adults, such as like impact sports or when falling at home. You might even see it with forceful twists or pulling with the wrist. An example being using a wrench as a mechanic, like forcefully, or lifting heavy suitcases when traveling. Degenerative causes, on the other hand, tend to occur over time. This can be with repetitive motions in pronation, supination, or even consistent load-bearing activities with the wrist and ulnar deviation more specifically. So manual labor activities, perhaps a hairstylist performing similar tasks repeatedly, or even someone with hypermobility who overstresses the joint without even realizing it. So why does this matter? These injuries will often impact occupational performance all in all. Even if the clients don't immediately recognize the source of their symptoms, they will often report difficulty in doing tasks that require like grip strength, wrist and forearm stability, or rotation of the forearm, like when they're opening jars, turning keys to open their door, lifting heavy objects at work or at home, pushing from a chair to get up or off your bed, or even honestly affecting like sexual lives. We have patients who might start to avoid using their hand or perhaps guarding it, so which over time can increase weakness, deconditioning, create a loss of independence in self-care or home management tasks. So it'll be important for you to provide a thorough evaluation, and listening to your patient will be key so that you can catch this and treat it early, especially as the condition, so a TFCC tear, will often not be isolated and instead present itself with another injury or condition. So throughout this module, we'll build your confidence in understanding, recognizing, and treating these cases using OT-specific interventions and reasoning. So let's look at the relevant anatomy. So on the left here, we're highlighting the distal radial ulnar joint, or the DRUJ, as it is closely connected and relevant to the TFCC function and dysfunction. The DRUJ is a joint between the distal ends of the radius and the ulna, and it's what allows us to pronate and supinate the forearm. So we use this often when we're turning a doorknob, opening jars, using tools, or even pouring drinks from a pitcher. So kind of like think of all the functional treatment activities here that you can do with these kind of movements, you know? So the DRUJ is relevant as it has a special relationship with the TFCC, and its stability is crucial for proper and painless functional use of the wrist and the forearm. So things such as malalignment after injury or ulnar variance can have an effect on an individual's ability to functionally use their hand. And I'll go more in depth on this topic in the next slide, I think. But when evaluating a client, you always want to consider the mechanical relationship between the DRUJ and the TFCC. So a dysfunction in one almost always affects the other. I mean, we're working in a small space here. So this is why your role as an OT is not just to treat the pain, but also look at the movement quality, joint stability, and the impact it has on functional tasks. So let's look at the TFCC. So this is the key structure involved in many cases of owner-sided wrist pain, and understanding its parts will help guide both the evaluation and treatment decisions. So what is the TFCC? It's a group of interconnected structures on the ulnar side of the wrist, so kind of on that pinky side, and together they act kind of like a shock absorber and a stabilizer at the same time, especially at the DRUJ, as mentioned in the previous slide. So the major components of the TFCC include the articular disc, also called the triangular fibrocartilage itself, and its central portion of it is the central portion of the structure. So this structure is avascular, meaning that it doesn't really heal very well once it's torn. So it's kind of a bit of a bummer when this is injured, just because it's going to be a bit of a lengthy process. Next, we have the dorsal and palmar radial ulnar ligaments. So these help stabilize the DRUJ during rotational movements, like turning a doorknob or using a screwdriver. We have the ECU tendon in the sheath. This structure acts a bit like a sling to guide the support of the ECU tendon as it crosses the wrist. This structure is especially important as ECU tendinopathy can either mimic or accompany TFCC injuries. And then finally, we have the meniscus homologue. So this is a connective tissue remnant that helps anchor the complex to the triquetrum and the hamate. So together, these structures allow the wrist to handle load transmission across the ulnar side, especially when weight bearing throughout the hand. So like doing yoga, pushing off a chair, lifting objects. But I want to mention how like when we use our hands for like pushing or grip, most of the force travels through the radius. I mean, it's the larger bone of the two. And so it takes in about 80% of the load, whereas the ulna handles the remaining 20%. Now, if something were to happen to the normal alignment between the radius and the ulna, so likely a poor healed distal radius fracture or instability at the DRUJ, then additional stress gets placed on the ulnar side of the wrist, and the TFCC is at a higher risk of being injured through increased load and demand. So ulnar variance will also put the TFCC more at risk, as it can shift how those forces are distributed and make the TFCC more vulnerable and susceptible to degeneration or injury. So as OTs, we need to be aware of this when clients report ulnar-sided wrist pain after injury or surgery, as the TFCC can be overloaded and it can lead to instability, weakness, and significant pain with functional use of the hand. So it'll be critical for us to know what we're working with and what will aid in planning and interventions that involve rotation, grip, and weight bearing. Next, let's look into the clinical presentation aspect. So what does it look like? The hallmark symptom is obviously wrist pain on the left side of the wrist, so on the ulnar side of the wrist, so near the pinky side, often just distal to the ulnar head. Clients may also report clicking, popping, or catching sensation within the wrist, so that crepitus, especially during forearm rotation. That clicking will often indicate either instability in the DRUJ or a torn TFCC that is getting pinched with movement. A very common functional sign is weakened grip. Clients might say that their hand doesn't feel strong anymore, or they can't really trust it when lifting heavy things. Grip can be especially reduced when the wrist is in ulnar deviation or in rotation as well. And so when it comes to daily function, you'll hear complaints that involve ulnar and radial deviation and forearm rotation in general. So specifically that supination and pronation. And then let's look into some provocative testing that may be included in your evaluation. So we have the TFCC load test. So essentially, with the client's forearm stabilized, you place the wrist in ulnar deviation, apply a gentle axial compression, and place the wrist into ulnar deviation. So the reason the TFCC load test is so helpful clinically is because it mimics the exact forces that stress the TFCC during real life activities. So when the wrist is placed in ulnar deviation, and you apply compression and then rotate it through pronation or supination, we're targeting the specific region where the TFCC resides, so right after the DRUJ. In a healthy wrist, the TFCC absorbs and manages that force without no problem, no issue. But if there is a tear or degeneration, those same forces can cause a client to feel pain, clicking, grinding, or even signs of instability. What is cool is that this test doesn't just tell us what something is wrong, it replicates the client's actual symptoms, which builds kind of like a stronger clinical case. It's kind of like stimulating a functional movement under a very controlled condition. So when we're doing this test, we're basically asking, how does the TFCC respond when it's under pressure, the way it would during tasks like twisting a jaw or pushing off the floor? The next one we have is the ulnar fovea sign. So essentially, you position the client with their forearm in neutral or slight supination and the wrist relaxed. You locate the ulnar fovea, so the soft depression between the ulnar styloid and the FCU, and then you'll apply a firm palpation with your thumb or fingertip to the area, and it's considered positive if it's reproducing pain or tenderness at the site. So the ulnar fovea sign targets a very specific anatomical region, which is essentially that soft spot where multiple important structures come together. It is located just distal and slightly dorsal to the oral styloid, right between the bone and the FCU tendon. When we press here specifically, we're putting direct pressure on the dorsal portion of the TFCC, especially the deep fibers of the radial ulnar ligaments and the ulnar triquetral ligaments, which lie very close to the surface of this area. So again, in a healthy TFCC, this palpation is typically not painful, but if there is a tear, inflammation, or degeneration, the client will almost always report a sharp or localized pain when you press into that fovea. That's why it's considered one of the most sensitive clinical signs for detecting TFCC pathology. So this test is especially helpful when a client doesn't have swelling or obvious dysfunction, but still complains of that ulnar-sided pain with tasks like lifting, rotating, pushing through the wrist. So as an OT, this helps us guide towards appropriate splinting, activity modification, or referral for imaging, depending on each individual case, really. Next, we have the press test. So this one's pretty simple. From a seated position on a chair or perhaps a table, you have the patient lift themselves from the chair with wrist extended. So, I mean, it's a simple yet useful tool as it mimics real life functional movement that places stress on the ulnar side of the wrist. So when the client pushes up from a seated position using their hands, the wrists are placed into extension and slight ulnar deviation. This creates an axial load through the distal ulna and the TFCC. This is also very similar to the forces experienced during daily activities like getting out of bed, using mobility aid, or pushing a door open, especially if it's a heavy one. So again, if there's a TFCC tear or DRUJ instability, this position will reproduce pain, cause discomfort, or even sense kind of feel like the wrist is kind of giving out or away. Let's look into the evaluation and treatment. So initially, your primary goal will be to reduce pain, protect the injured TFCC, um, and that's kind of the forefront. You'll want to inform the patient that they'll want to avoid heavy lifting, rotation activities, pushing through the wrist for the initial time being until we can kind of reduce that pain. Orthoses like the ulnar gutter splint or the wrist widget can help unload the TFCC and promote healing. So the image on the left is the ulnar gutter splint. And so this one's a prefabricated version. However, you can always make a custom one with like thermoplastic. On the right is a wrist widget, which I provided an article about this guy, so you can read more and dive into that rabbit hole. But with inflammation also, ice can be a very useful tool. Even heat can help with pain at the beginning and end of therapy sessions. Think back on the PAMS module. Challenge yourself to like trial what will help the patient based on their symptoms and needs. Lastly, you'll want to educate the client on how to protect the wrist during activity and stress performing tasks with the wrist in neutral or using both hands when lifting objects instead of relying on that one. Once pain is reduced, we move into the stabilization and strengthening phase. So this phase focuses on restoring wrist and forearm motion without aggravating the joint. Starting with isometric exercises and progressing to more dynamic strengthening is often an effective way to approach strengthening in this instance. So isometrics are useful initially as they kind of like strengthen muscles without moving the joint, if that makes any sense. We're minimizing the stress that's being placed on the healing tissues or ligaments in this instance. So they will help preserve muscle function and stability early in the rehab process. And once pain and inflammation improves, we can progress to a more dynamic movements and more functional strength. So the goal in this phase, restore movement, build controlled strength without re-irritating the TFCC or destabilizing the DRUJ. So this will typically begin with gentle range of motion, especially with forearm pronation, supination, which are again key movements of the TFCC. So active assisted motion can be utilized first prior to progressing to full active range of motion. Use your best clinical judgment depending on the patient and the symptoms they're experiencing. But it'll be important to monitor for pain or catching which might indicating that you might be progressing too quickly. Another thing I'd plug in is proprioceptive retraining will also be relevant as the body often loses its fine joint position awareness. So closed chain tasks with tolerance can be utilized, such as weight shifting on a table or a soft surface, rhythmic stabilization with resistance. You can use that flex bar I mentioned earlier on, or even rolling ball exercises on the wall or table to regain neuromuscular control. Functional grip and lift activities can be utilized as well. And you can begin with simple squeezing like resistive putties or foam cubes, but you can also work towards like carrying like lighter objects and like maybe even resistance bands. But again, progress slowly, progress with what you see you can do, what the patient can do, and try not to exceed that 4 out of 10 pain. And so for the next transition, moves from isolated strengthening into full functional use of the wrist and the forearm. This is where we tie all of the rehab back together into their occupational goals. You'll gradually reintroduce weight-bearing tasks. So this can be through having them bear weight through in being in quadruped, trying modified push-ups or weighted wrist exercises or resistance bands even. Then we'll focus on task-specific training. So if the client struggles to open jars, you can practice graded grip and rotation with resistance. If turning a key hurt, then you can stimulate the motion with various different tools in your clinic. And then you can reintroduce various everyday tasks in a gradual manner within the clinic. And this is where, honestly, you can get very creative. Um, Compensatory strategies or ergonomic education can also be utilized if necessary. For example, you may teach your client to use their palm instead of the fingers when opening heavy doors, or to naturally lift objects with both hands and closer to the body rather than creating stress only on one or performing like unnecessary movements at work or at home. So as you approach discharge, you'll continue to give and update your HEP with your client. That includes strengthening, flexibility, and protection strategies, and how to modify tasks if pain returns. And so really this phase is all about bridging clinical gains with meaningful occupations. So making sure that the client not only heals, but also feels confident and capable in like getting back into the things that they need to do. Um, but just kind of like a little plug-in piece there of kind of how to tie in that eval and treatment. But all in all, that's all I got for you. Here are my references. If you want to dive into deeper rabbit holes, feel free to kind of read and go in depth into these. There's also great videos available online. Or if you have any of those textbooks, I know Therapy of the Hand has a really great TFCC owner-sided wrist pain section. Or if you have access to MedBridge as well, and Pareto does a really great job in talking about this topic. But once again, thank you so much. And it's been a pleasure teaching to you guys.